All right, can everyone see and hear?
Yep.
We'll wait just one more minute. While we're waiting, has anyone seen this map? This was in the New York Times today, a map of yesterday's low temperatures across the country. Look at that. I mean, we're balmy down here and it feels freezing outside. I mean, look, Texas with a temperature below 0.
Reasons number 18 through 58 why I left Indiana.
That and the frozen cows. Sorry, JT, if you're listening. All right, everyone, let's get, so this is the CMA code. I will put it in the chat section as soon as I stop the slides. Again, it's really cold out there across a huge part of the country. The COVID numbers continuing to look good in our area of the world. The top numbers are state, both the state cases and finally state deaths are starting to come down reliably. In our local area, the bottom, which are the admissions to Duke Hospital, are down steadily. And the percent positivity has been steadily trending down to 5 or 6%, which is really good compared to where it used to be. A couple of announcements. As most of you know, double masking is now, recommended, not required at Duke, but Duke has supplied Duke approved cloth masks, which are available either at Maureen Road in the doctor's or provider's room at our Duke South office space or at my office. I'm not sure if you can wear your own cloth mask now. Does anybody know the answer to that, or do you have to wear a Duke supplied one? No consensus? Just put it in the chat if any of you have official word. This Thursday at 5:30, Atif, who is our PDC at-large member, is going to hold a special faculty meeting around integration. And then just an announcement I heard this week that early May, all our inpatient services are moving to the new Duke Center Tower or relocating within it from the bottom to the top. And I want to stress that those are not actual images of the center tower on the left. Vaccination rate in the state is 11.4% for 1 dose, 4.2% for 2 doses, which puts us pretty much in the middle in the United States. The headline is from the Herald Sun. There are still pervasive inequities around who's getting vaccinated. And all I can say to you folks is, I think if you talk to your patients about it, it might affect their opinion somewhat. I know in Emory Clinic, we've been talking to all our patients about it. And I don't know how many minds we've changed, but they've all been receptive to hearing what we have to say and hearing that we've had it done and kind of came through it okay. Some announcements, Kimberly Smith-Walters and Mercedes Carrillo, who work in the 1L clinic, have been, from Lindsay Anthony, have been volunteering at COVID clinic on weekends in addition to their usual work. And they are this week's All-Stars. And research highlights Sneha Mantri published a study on depression and its association with cognitive impairment in Parkinson's disease. And Sri Shah and Ying Zhang published a paper on how post-stroke depression affects discharge rates and readmissions, both treatable potentially. An announcement, the great David Z is going to be doing grand rounds next week. It's a joint grand rounds with Duke's head and neck surgery department, and it's going to be at 7:30 in the morning rather than the usual 8. Dave Z is a world famous teacher and expert in vestibular imbalance, and I'm sure that everyone will love hearing that. So today's case presentation is Hui Zhang, who's our fellow in Parkinson's and movement disorders. And Hui, I'll switch it over to you. You should be able to share the screen now.
Okay. Good morning, everyone. The name of my presentation is The Mysterious Dance of the Shoulder. Sorry. So today I'm going to present a case we saw in the clinic. This is a 44-year-old woman presented with right shoulder abnormal movement. She had a right rotator cuff injury in May 2018. Shortly after injury, she started to have the right shoulder involuntary movement, which got worse after rotator cuff repair in September 2018. So touching certain area in her right shoulder or excessively moving the right arm can trigger the movement. And these movements were preceded by pulling sensation, but there are no urge. The duration can be from 30 minutes to 1 hour. And the abnormal movement can be alleviated by sling position or voluntarily using the right arm. She has pain in the neck, also posterior aspect of the right arm. She has right arm hypersensitivity. Her right hand intermittently turns blue, but not necessarily related to the movement. She has a past medical history of ADHD and also compulsive disorder, and family history of tic disorder in multiple family members. Her father has compulsive disorder. She has not exposed to dopamine receptor blocking agent except Phenergan for a few weeks after surgery. She is on Valium for anxiety, which partially help the abnormal movement. So she is on Tramadol for the pain. So for the exam, general exam showed right arm hyperalgesia. So now let's take a look at the movement disorder exam. So we can see the proximal right scapular area, involuntary, semi-rhythmic, repetitive, and writhing and jerky, just a little bit jerky, and auto-rotary motions. So I didn't show it in the video. When she actively using the right arm, the movement can be slowed down and finally stop. There are no tremor, no bradykinesia or rigidity, and there are no abnormal posturing. Okay, so she had extensive workup, which were all unremarkable. So the phenomenology we described in the video represent focal dyskinetic movement. So according to the paper published in JAMA Neurology 2019, we diagnosed the patient with dancing dorsal contralateral syndrome, which is a presumed novel peripheral induced movement disorder characterized by neuropathic pain preceding a regional movement disorder, but usually following soft tissue or nerve injury. So as you know, other peripheral induced movement disorder include painful leg moving toe, post-amputation dyskinesia, and belly dancer dyskinesia. There are no validated diagnostic criteria. The differential includes functional movement disorder, dystonia, and tics. So the cause of this unique phenomenology is due to sequential or alternating semi-rhythmic contractions of different parts of the trapezius, so which explain the unusual semicircular motions. So if EMG is successful, it will capture long duration bursts of normal motor unit potential with normal recruitment pattern. So unfortunately, there are no successful treatment for this syndrome. Usually it is refractory to multiple oral medications, and botulinum toxin may be beneficial initially, but usually the movement will come back according to the article. So we decided for this patient, we're gonna do Botox injection to the right scapular area when she come back for follow-up. Yeah, this is my case presentation. I hope you find it helpful. You can recognize this phenomenology in your patient. Thank you.
Thank you very much. Very much. So Andrew, we'll turn it over to you.
Hey, good morning. So first of all, let me just acknowledge it's Ash Wednesday. So those of you who are observing, I hope you have a meaningful Lent coming up. But now I'm very pleased to introduce our guest speaker. It's Dr. Aaron Anderson. And I met Aaron a year ago at the AAN conference, and it's amazing. I feel like I've known him for much longer than that. And I'm excited to share with you that yesterday he was announced as Emory Neurology's first Vice Chair of Diversity, Equity, and Inclusion. So huge congratulations to him on the first morning since his promotion. And Dr. Anderson is a vascular neurologist and neurohospitalist at Emory. And he's been on staff of the Marcus Stroke and Neuroscience Center at Grady Hospital since 2010. And before taking that faculty position, he was an undergraduate at Xavier University in Louisiana, attended medical school at Indiana University, and then he completed his neurology residency at the University of Alabama at Birmingham, where he trained alongside the one and only Dr. Chris Eckstein. He stayed at UAB for his vascular neurology fellowship and obtained additional specialization in neurovascular ultrasound, which is the subject of his talk today. And Dr. Anderson built the Marcus Stroke Neuroscience Center's neurovascular ultrasound lab from performing just 34 scans in a whole year to becoming only the second transcranial Doppler lab in Georgia to receive national accreditation. His goal is to train additional vascular neurology fellows and technicians to expand the role of neurovascular ultrasound. So a warm welcome to Duke, Aaron, and I'll turn it over to you.
Absolutely, thank you. Thank you very much. I very much appreciate that. I'll go and start sharing my screen. And all right, everybody has a screen, and please feel free to throw questions into the chat. I'm fairly good about trying to answer those as they pop up, and we will make it through this presentation mostly unharmed is my goal. So no disclosures to present. I just want to acknowledge Dr. Fang and Dr. Spector for the invitation to present today, and as well as the wonderful work that my fantastic techs, both Kim Hodge and Karen McEwen, have been doing through the years for the Marcus Stroke Neuroscience Center Neurovascular Ultrasound Lab. So the goal of this talk is that we'll talk about ultrasound, some Doppler principle. I apologize for physics this early on a Wednesday morning, but that will come up. And talk about the carotid ultrasound, the parameters that we use, as well as TCDs. And then we'll kind of go through the fingerprints or the waveforms and how that can help us guide treatment plans, not solely just on the velocities of the carotid ultrasounds or TCDs. So I'd like to go and start with a case. And this is a 63-year-old male that was had syncope, continued dizziness, was at an outside hospital, and they requested transfer to our neuro ICU for close monitoring after what was found on this CT angiogram. And this is using the Viz AI software, where we're able to have images pushed directly to our stroke team. And as you see, the highly calcified vertebral arteries here, and then that progresses to where there's a proximal occlusion, and then looks like quick reconstitution of the basilar artery. So as we go through that just one more time, you can see how both vertebrals are patent. However, once they get intradural, again, there's calcifications here, followed by occlusion or appeared occlusion of the proximal basilar, and then quick reconstitution of the basilar artery. So patient was transferred in and for further evaluation. Patient did have some mild ataxia. There's some saccadic eye movements. was not orthostatic, and even with sitting the patient up, trying to determine, do we need to acutely go in and revascularize the proximal basilar artery with our endovascular colleagues. Ultimately, without worsening, we were able to wait till the next day. The MRI was completed with the MR angiogram, of course, showing that proximal basilar. The caveat on the MR angiograms, as we know, is severe stenosis versus occlusion, and they recommended a CT angiogram. At that time, the images were not yet pushed into the PAC system, so they weren't able to review them as we had. Echo was normal, no PFO, and our question was, would an angio for this gentleman help with the case or not? Would it put undue risk or not, knowing that it's a diagnostic, which has an extremely low risk of having any complications? And the thought, if we did go in and think about stenting the proximal basilar artery, would that then cause more damage to the brainstem with the basilar perforators? So my question that I posed to the group, and I hope to bias you by the end of this talk, is, would a carotid and a transcranial Doppler help in this scenario? We already have a CT angiogram, we have an MR angiogram, yet what benefit would a carotid and TCD do for the management of this gentleman? Talking about sound, so sound waves carry energy. Infrasonic is anything below the 20 hertz, and ultrasonic is anything above 20,000 hertz. When we talk about the history of ultrasound, it goes back to 1794, observing bats flying around in the dark, and kept moving the obstacles around, and the bats continued to not run into the obstacles. Hypothesized maybe they were being guided in some fashion by sound waves. Johann Christian Doppler, the reason why anytime you write Doppler in a Word or PowerPoint document, it automatically capitalizes it. Because he proposed the theory known as the Doppler effect. It was not about sound, but it was about, he was also an astronomer on the side, and he described the colored light of a double star system. For those of you that can read German, here's the title of the paper. But what he observed was, as the two stars were orbiting around each other, each time the star from the left got to the right, it changed the color of the star. Yet it was the exact same star as it was when it was on the left side of that orbit. So he hypothesized that maybe the direction that that star is moving in space relative to us affected the wavelength or the frequency of the light traveling here to Earth. 1845, this theory was confirmed using horn players on the back of a railroad. I like to kind of think this was one of the first times that I have not yet seen a train without a whistle or some type of horn. So having actually horn players in my mind, I think this is the cousin of Bides Bollet, who said, I got a band, can you give us some work? Using some research dollars to try to confirm Doppler's theory. It was confirmed using the horn players, noticing that the frequency did change as the train was passing by the location. 1880, Pierre and Jacques Curie, they discovered, among other numerous discoveries, the piezoelectric effect, and we'll go through that on the next slide. 1959 was the first time that Doppler was used to measure arterial blood flow. Initially, this Doppler arterial blood flow was just continuous Doppler, which means you could listen, but you had no idea how deep the artery was that you were insudating. So you would be able to determine, yes, there is adequate blood flow, or yes, the pulse rate looks good, but you couldn't determine how deep that vessel was. 1982 was the first time that transcranial recordings were used for the basal cerebral arteries, the proximal MCA, ACA, vertebral and basilar arteries. The piezoelectric effect, again, is from Greek, the piesin, meaning to press, and it's a property of crystals that create a voltage anytime that that crystal is mechanically deformed. The reverse piezoelectric effect is when that material will deform if when a voltage is applied. This is used in 1929 was the first time that quartz was used to help keep time in a clock because of that reverberation continuous that was noted for quartz crystals, and be able to use those in clocks, watches, and now we use multiple different other materials for our ultrasound probes, microphones, record players. So the key here is that we don't want folks to drop the probe because that crystal will break and then the images that we receive become non-functional. So everybody's very careful when you're using the ultrasound probes. Pulse wave Doppler allowed us to now not only listen to the arterial blood flow, but also determine how deep an object was. So now not just blood flow, but you could use Doppler to look at actual tissue and then present that on the image screen to then show you how deep each level of this tissue was. By sending a pulse, you're listening a lot longer than you send the pulse, and that allows you to use time to see how far that pulse traveled and returned back to the transmitter. And then that is then presented in the image format. This Doppler principle, it is a transmitted wave of a given frequency which hits a moving object. Hits a moving object which is reflected with a frequency shift that is proportional to the velocity of that object. There'll be a quiz on this later, so please remit that to memory. When we're thinking about frequencies, this is kind of visualizing what the waveforms of the waves of the ultrasound pulse are doing. So low frequency and a long period between each amplitude. And here, this is a high frequency and a short period. So frequency and periods are reciprocals of each other, and trying to determine what is the frequency shift as the ultrasound pulse waves traveling in and is reflected back. That frequency shift is what allows us to determine the velocity. When you're watching the Australian Open semifinals tonight and you see Naomi Osaka hit a ball towards Serena Williams, if Serena is running away towards the baseline and she swings her racket the same speed, the ball will then come off her racket at a lower relative frequency compared to the ball that was traveling in. However, if Serena is moving towards the net, that frequency shift is now positive, and with the same arm swing, as the ball is reflected off the racket, it comes off at a higher speed because of that change in frequency shift that you see, whether Serena's going towards the net or going away from the net. Here's the warning for the physics equation. I apologize. Yet when we talk about Doppler frequency, it's really, we're looking at the Doppler frequency shift. The original Doppler machines to measure blood flow would give results out in Doppler frequency shift, and then the reader or sonographer would have to then relate that into velocity. Now we have the computers that do that math for us. We know the other variables. What we're looking for is the velocity of the moving blood cells. We know the ultrasound frequency of the probe that is being transmitted in. We know the velocity of ultrasound in tissue. And then the beta is the angle of inclination. So on transcranial Doppler, we are assuming a 0-degree angle, because as we're listening through the skull, you're not able to angle correct as you are in the carotid. So that for TCDs, you're assuming that the blood flow is coming directly towards the probe and not turning or changing direction in any fashion. Here's our frequency shift equation, to where that Doppler frequency shift is going to be relative to the velocity of the object or the blood flow that we're looking for, that frequency that's being transmitted from the probe going from the machine into the body, and then that velocity of ultrasound in tissue. The question we're answering is how fast is that blood flow actually going through that blood vessel? So when we see that velocity just moving the equation around, everybody knows from geometry that the cosine of beta is 1. So for TCDs, you're essentially taking that variable out. We have the known 2 megahertz probe, and you know how fast the sound waves are traveling through soft tissue. So now what you have is that the Doppler frequency shift has a linear relationship with the blood flow velocity. So as that shift increases, whether it's negative or positive going towards the probe or away from the probe, that velocity is relative to that Doppler frequency shift. Here's a random quiz here. Again, if I'm saying that my green wave is what is being transmitted from my 2 megahertz probe, TCD probe, which has the highest velocity towards the probe will be the purple line. And this purple line has the highest frequency shift compared to the green. If we look at which one has the slower velocity going away from the probe, you're now looking for a negative frequency shift. And now the red has a greater frequency shift, which means it's going to higher velocity compared to this yellow-orange line here. So this one has the slower velocity going away from the probe, comparing the frequency coming from this green line, which is our TCD probe. When you think about hemodynamics with stroke patients, there's multiple factors that affect that flow. And of course, stenosis, there's the pressure difference, you have resistance, and then you have fluid viscosity, the radius, and then the amount of the volume going through that tube. So when we're looking at here, the Venturi effect, again, as the same volumes going through a constricted area of blood flow or stenosis, you have an increased velocity with a decreased pressure. And that pressure difference is also what's causing that increased velocity. What I'm going to do here is I'm going to flip this image around, just because every carotid Doppler that you look at and review, the heart is to the right and the brain is to the left. So the blood flow is going from the right of the screen to the left, yet that principle of how much stenosis there is then relative to the stenosis. That's why on carotids, you never get a direct exact degree stenosis, because it's based relative on that velocity. Again, the length of the stenosis is more important than how severe it is. Yet we do know that the radius, so if you have a very short severe stenosis, it's not as severe effect on the hemodynamics of the blood flow than if you have a longer length severe stenosis. The radius of that stenosis has an exponential effect. It's to the 4th power. So any reduction in that radius has a significant effect in blood flow going through that stenosis. When we look at the hemodynamics, the waveform of our carotid Dopplers and TCDs, you can see some clues about what's happening with the heart function, especially if you're looking at the global effects of this cardiac output. We're going to move on to kind of talk about the terms of the carotid and TCDs with some of the parameters. Again, when we think about stroke, we're mainly looking at ischemic versus hemorrhagic. Now, TCDs are used a lot with subarachnoid hemorrhages, looking for vasospasm. However, for carotids, we're looking for kind of help determine the stroke subtype, whether we're atherosclerotic, large vessel disease versus cryptogenic, and we're trying to reduce the number of cryptogenic strokes. And carotids and TCDs can help with that. Again, the majority of what we're looking for is atherosclerotic disease, and that's going to be with the carotids and with TCDs looking for the elevated velocities. However, there's additional information hidden in the waveforms that we'll be able to discuss. Carotid plaque, you can imagine here, if this is the normal lumen, that residual lumen that's here is markedly reduced. Again, to the factor of 4, this is going to cause a significant reduction in the amount of blood flow that's able to get through that degree stenosis, and the velocities would be very much elevated going through that plaque. Multiple indications for carotid Doppler. Again, what we're using them mainly for is stroke or TIAs. They can be used for syncope. Having a bruit is not an exact science. So if you have a bruit, you will sometimes occasionally find a stenosis, and it is not 100% that if you have a stenosis, the patient will also have a bruit. We do use it as a risk prediction for like major cardiac surgery, performing carotid Dopplers for our cardiothoracic surgery program as well. So trying to answer these many different clinical questions, it's really trying to say, ultimately, can this Doppler assist with the care of the patient either now or in the future? And using carotid Dopplers up front to not just identify that stenosis, but to have a baseline so that during follow-up, if we see a change in that velocities, we can then potentially recommend change in medication or intervention at that time. Our B-mode imaging, again, this is obtained using the pulsed wave Doppler. With the pulse wave, the pulse is coming in and you allow time for the signal to reflect back to the probe, and the computer is then able to indicate the depth of the vessel or the depth of the reflector that we see. Again, the brighter the reflector, the more echogenic it is or dense. So when we see something that's very echogenic or hyperechoic, we would, in the plaque, we would consider that to be a calcified plaque. However, stents are also hyperechoic and other things that you can identify on the B-mode imaging. The plaque features can help because if you have somebody who doesn't have elevated velocity going through the plaque, which means the CT angiogram also has a less than 50% stenosis, yet with the carotid ultrasound, you see an irregular surface with an ulcerated plaque. That's a patient who could have had a larger stenosis, yet with the plaque rupture, it is now less than 50%, but the ulceration can give us a clue that this is a very thrombogenic process that would consider for revascularization or just adjustment of antiplatelet regimen. Again, if I'm going to just go back here. So if you're looking at the B mode and you see movement of the plaque, or you see a mobile thrombus, those are definitely phone calls that you make to the treatment team that you can identify acutely with the ultrasound. Now, getting that flow direction, peak systolic velocities, again, the waveform pattern is kind of the fingerprint of that vessel, giving you an idea of what's happening, not just proximal to the vessel, not just at the site where you're intubating, but also in the distal segments of the vessel. Kind of combining that B-mode imaging with the pulse wave and color Doppler gives us that ability to have a 90% sensitivity specificity for a tight stenosis. The reason this is not 100% is that it is a tech-dependent study trying to identify the location of the highest stenosis through the vessel. The Society of Radiologists and Ultrasound had a consistency criteria for the calling degrees of stenosis, and there's primary parameters, secondary parameters. If you go off of just looking at the final chart on carotid ultrasounds or TCDs, you'll probably be about 85% accurate on actually identifying stenosis if you just follow these primary and secondary criteria. The question here is if you have elevated velocities, yet our ratio is not elevated between our ICA and our CCA, it still might represent a stenosis or it might represent other causes. And that's why looking at the waveform can sometimes help determine, is this an actual stenosis or are we to the point where it's a near occlusion and the velocity criteria may be low because it's such a severe hemodynamic significant stenosis. This is just an example of a tech-dependent study. Again, using the secondary criteria, the end diastolic velocity being above 100 is a criteria you can use to determine a 70 to 99% stenosis. patient comes in with a TIA or a small stroke with this finding, this is a patient that will most likely go towards revascularization, whether it be with a stent or endarterectomy. However, insunating the difference between this location and just about 2 millimeters further distal along the vessel, our peak systolic velocities are still elevated, yet our end diastolic velocity has now dropped below 100. So using both the primary and secondary criteria, this could now be read out as a 50 to 69% stenosis that, depending on how aggressive your center is, this patient might be delegated towards medication therapy and not towards surgical revascularization. The Spencer curve is where I mentioned that if it is a severe stenosis, the velocities may actually reduce, and that determines where you are along the Spencer curve. You can see that our blood flow volume remains fairly constant, even with the stenosis getting up to 50, 60%. Once you're above that 60%, you start to have an increase in flow velocity that corresponds to a slight decrease in our flow volume. When you start to get above 80%, that flow volume is reducing, such that if you're above 90, 99%, you're going to have a reduced flow velocity with decreased blood volume going through that severe stenosis. On CT angiograms, this would be a string sign. MR angiogram, it would most likely be a flow gap. So it would be a possible severe stenosis versus occlusion. And using carotids, you can determine, is it a patent vessel, and would revascularization be beneficial? Or if it's already completely occluded, there may not be any intervention necessary at that time. If you're unlucky enough to have a light bulb put inside your skull, you'll see that there's multiple windows that we can use to insunate the basal vessels, the MCA, ACAs, PCAs, as well as your vertebral and basal arteries. So using the transtemporal window, the orbital windows, or the suboccipital windows to get through the foramen magnum are the locations that we can use to insunate our intracranial vessels. Again, TCD, we're looking mainly at these proximal vessels. Transtemporal, orbital, and suboccipital, you're going to be insunating different vessels along the way, and the direction of that blood flow matters and can change or give a better clue of what is happening with an acute stroke with a thrombus, looking at the collateral flow. Using a lot of the main parameters with the peak systolic velocities, our end diastolic velocities. With TCDs, there's an added parameter of pulsatility index. You can see how much resistance is present in that vessel by looking at the difference between our peak and our end diastolic velocity. That low resistant waveform, you're going to have a good upslope, and that means that there's no severe stenosis between the heart and where we're insunating. That downslope is a nice slope that's coming down without high resistance. If there's high resistance, it's going to be a steeper or higher grade downslope, which is indicating a very distal stenosis or abnormality in that vessel. Multiple clinical applications. Again, during an acute ischemic stroke, you can use TCDs to try to assess collaterals, monitor recanalization. What really got me interested in TCD was I was at UAB while Dr. Alexandrov was present. And during an acute stroke, he came down with a handheld TCD device that he was testing from Germany somewhere. And he put a probe on this patient's left eye who was rolled in for an acute stroke, had the left gaze, had the aphasia. And we were trying to get them to a CT scan so we can say, is this a TPA candidate or is it a hemorrhagic stroke? And within about 6 seconds of having the probe on the patient's left eye, he left the room saying that he was calling the interventionalist to say that there was a tandem occlusion in the ICA as well as the left M1. We, of course, got to the CT scan, gave TPA, and the CT angiogram confirmed what he had already found about 15 minutes before that. And at that time, the angio suite was ready for us to arrive with the patient. What I now know is that he saw reversed ophthalmic artery with still high resistant flow. And the only reason that that reversed ophthalmic would have high resistance is if there's also a thrombus present in the M1. So the only vessel filling from that terminal ICA would be the ACA vessel. Again, we use TCD as a monitor for vasospasm following subarachnoid hemorrhage. We can detect right to left shunts. TCD will never be able to definitively say, is it a PFO or is there an AVM or some other shunt present somewhere? Yet trying to determine the grade of the right to left shunt can be done with the bubble study, and it's actually more accurate than a echo with bubble. Rotterdam did do a population-based study for TCD. Again, what they found was that over the 5-year process, individuals that had the highest velocity had almost a 2 times increased relative risk of stroke compared to those in the lowest tertile. Again, this also showed where that higher velocity was indicated of a more severe intracranial stenosis finding for this population of 2,000 folks out of Rotterdam. Now, compared to CTA, there is a lower sensitivity. This is because also a tech-dependent study. Also, if there's no temporal windows for us to be able to incident through, and if we don't turn or angle correctly, you might miss the degree of stenosis in one of the M2s. TCDs also can't really incident out to the M3 or M4s because at that point, the angle of incidentation becomes too great. And if you're at 90 degrees, you have no Doppler effect going to or from the probe. The caveat of that is if you find an elevated stenosis, it has a 94% specificity that there is a stenosis of some type or vasospasm happening in that vessel. So it's a good screening technique, especially for our subarachnoid patients. And in this example for acute stroke to try to determine that real-time flow and provide that complementary information between the CT angiograms and MR angiograms. Again, both the CTA and MR angiogram are static images. They show us that one point in time what is happening to the blood flow. However, with TCDs, you're actually getting that physiologic effect. You can follow that blood flow. You can see and try to determine what's going on proximally and distally while incidating through that vessel. The clot bus trial was initially done, small trial with 126 patients with 2 hours of continuous TCD, no increased rate of symptomatic intracranial hemorrhage. And in this small study, there is a increased improvement following TPA in patients that had the 2 hours of TCD at the same time of TPA infusion. This was done in a larger, trying to look at larger patient base with a head frame that was putting TCD signal. Again, sound carries energy. So the thought that the sound waves from TCD would stretch the thrombus and it'll give more surface area for the TPA to work. However, this proved not to be effective in really changing that modified ranking score at 90 days, but there also is not an increased rate of symptomatic hemorrhage. So the thought is, are they going to try to change the criteria for and repeat this clotbuster trial in a different patient population, try to determine, can we reach out with ultrasound to assist patients prior to thrombectomy for their large vessel ischemic strokes. As I mentioned before, our collateral pathways, again, looking at our ECA internalized to our ICA, if you had that retrograde filling of your ophthalmic artery, that comes with a 100% specificity for having that ipsilateral ICA occlusion. And that was something that was, got me first interested in ultrasound, and now figuring out all these different waveform patterns has led me to where growing that Marcus Stroke and Neuroscience and Neurovascular lab. Brain death. TCD is one of the confirmatory tests you can use for brain death. Again, looking at that cerebral perfusion pressure, and as the ICP is increasing, you are decreasing your cerebral perfusion pressure. This is something that we've had. We had 2 stroke patients with large hemispheric strokes that on TCD, when we start to see losing that diastolic flow, patient was referred for hemicraniectomy, and you saw that diastolic flow return, whereas the patient was progressing towards that reverberation, which would cause global ischemia. Having that patient obtain that hemicraniectomy, again, this was a patient that was unexpected to have as large of a stroke, and most likely overnight had occluded a more proximal vessel, and then our TCD was able to observe that prior to any repeat imaging or the MRI for that patient, that then allowed them to get the treatment that they needed. Looking at the fingerprints and the waveform of the vessels, again, looking at the vessel gives us an idea of what is happening both proximally and distally. On carotid and the common carotid artery, your waveform has a pattern that is matching both the external carotid artery with the high resistant waveform pattern, as well as the continued end-diastolic flow velocity that's present in our low resistant ICA, internal carotid artery. When I look at the traffic pattern, one of the reasons why I also enjoy being in Atlanta is I get to use the map of Atlanta to try to describe the intracranial blood vessel flow to our patients, because everybody knows 285, they know the junction 75-85, and then coming in and splitting between 75-85 in downtown. When we describe that to patients around the Grady curve, we know that if there's traffic or an accident up I-75, it's almost bumper to bumper stop parking lot traffic, yet I-85 is completely patent and has low resistant blood flow, and that's our internal carotid artery. Yet when we leave Grady and hop on the interstate, you run into traffic, yet you still have some continued flow. And that's kind of the flow pattern that we see with our common carotid artery. There is some high resistance, yet continued flow. And once we get to the split, you're able to continue on with that low resistance through the I-85 or the ICA, and you have that high resistant flow to the ECA. I tried to look up the traffic pattern for Durham. However, over the weekend, there wasn't a lot of traffic that popped up on Google Maps, so I wasn't able to implant the Durham map onto here. But that traffic pattern, when once you get past the exit there, everybody's going, you're able to continue on with that low resistant pattern. That's what's happening intracranially. That changes, and you can get clues when you look at that proximal common carotid artery, where if you have that high resistant pattern with very low end-diastolic flow, it makes you think that there might be something happening distally in the ICA, because you have now lost that low resistant good end-diastolic flow. In this patient, the ICA was in fact occluded, and our ECA still had some diastolic flow. And in this patient, the ECA was providing that collateral flow to the ophthalmic artery, providing that intracranial terminal ICA flow. Back to our case, again, this patient, 63-year-old, will play this image again. As they're looking at the bilateral vertebral arteries, you can see that our proximal basilar lost flow, and then you start to see some filling with contrast. It's light at first, and then it gets very dense there. So the question is this due to a proximal stenosis, occlusion, and how can carotids help us with that? Our MRI, again, showed this appearance of stroke, and on the day 2 of arrival, we were able to complete that MRI. Patient was had these very minimal symptoms, was not orthostatics. And so here we actually did get the carotid and the TCD. And what we showed on the carotids are bilateral vertebral high resistant flow. And that high resistant flow pattern with absent end diastolic flow is indicative that there's a distal severe obstruction and occlusion of the basilar artery. Seeing it in bilateral verts, this read could be read as, yes, both vertebral are antegrade, which is the main thing that you get on the majority of studies. However, looking at this waveform pattern would be amiss to not point out that there's absent diastolic flow in both vertebral arteries. What the TCD showed was in this distal segment is that we now have flow above the 0 line, which means there's flow coming towards the probe in the distal segment of the basilar artery. And what this is showing that basilar artery is reversed and flowing down, which is why that initial segment of that proximal basilar artery had contrast, but it was not filling as densely as the distal segments. It's because that was the last segment to get the contrast from the CT angiogram. When we look at this MRI, now if we say this is a border zone infarct and not embolic appearing infarcts coming from the basilar artery, it's actually border zone infarcts between the pica and aica. And further history, when we went back and talked to the patient, his blood pressure meds were recently titrated up. He wasn't drinking as much water. He's been orthostatic, kind of dizzy when he stood up for years. So that combination is probably what led to his border zone territory infarct. He had already reduced back his blood pressure meds because he did not like being dizzy every time he stood up. So this patient, again, anytime we mention that multidisciplinary discussion, it is reviewing all these images, discussing with our endovascular acute stroke team, and coming up with what is best for the patient, and then involving the patient with that discussion, and seeing that at that point he was completely asymptomatic, and blood pressure was normal tensive. We determined that he did not need an angiogram, and he was just placed on antiplatelet. With this being an proximal occlusion, there was no acute intervention that we would have done because he has that adequate collateral flow coming from that distal basilar artery. Other things that you can see in the waveforms, you have that common carotid artery. Again, this looks like it's going to be an ICA occlusion. Yet when you get to the ICA, you see that low resistant pattern, but during diastole, you have that continued reduction of diastolic flow. For this patient, the absent diastolic flow in the proximal common carotid artery, as well as that decreasing diastolic flow in our ICA, is consistent with aortic regurgitation. Vertebral artery, so again, carotid Doppler is done for dizziness. You can see vertebral artery, and here this patient had a subclavian steal on this left vert, on the right vertebral artery for this patient. If this is the only time during our carotid Doppler that atrial fibrillation is captured, and it's the time where we had to change the battery for the telemetry monitor and it wasn't captured, this is an opportunity that's definitely going to change the management for this patient. So observing irregular cardiac rhythms, aortic balloon pumps. This is kind of what the volumes have done for our neurovascular ultrasound lab. Kind of even, of course, during the pandemic, we've also had slightly higher rates of stroke due to the hyperviscosity from COVID. So we did observe a continued increase even during the pandemic in 2020, and looking just continued growth of the ultrasound lab. So just wanted to thank everybody for the attention and continue to go out and find some good trouble.
Thank you, Aaron. This is Rich O'Brien. So we have a question from Stacy Bennett. Stacy, do you want to ask your question?
Can you guys hear me?
Yep.
Yes.
Oh, sorry, it took me a minute to unmute. So I'm curious to learn with the handheld device that your colleague was trying out during that stroke code. Have you all started using that device in an algorithm or any other ultrasound in your stroke code algorithms or another way at your medical center?
So right now, so no, Alexandrov is on a different plane when it comes to acute stroke. So yes, no, it's something where he still actively will use TCDs during acute stroke calls. And he's in Memphis now, but at Grady and at Emory, we don't have the bandwidth right now. I just have the 2 techs, and there's 1 tech at Emory. So the ability to go down for all the stroke alerts would be impossible. So it's not something that we are using in the acute stroke case. We're mainly doing it during that stroke evaluation. You know, the hope is I will have an army of sonographers one day and be able to use it during acute strokes, but we are not there yet.
Thank you. It was an excellent presentation.
Thank you. Carmen?
Well, hi, it's Carmen Graffinino. I'm one of the stroke intensivists here at Duke. It's not unusual for us to see patients coming in with an acute stroke to have what looks like a carotid occlusion. And as you know, the literature suggests that maybe somewhere between 10 and 20% of these are actually acute. When you do TCDs, do you, we've had a discussion among our folks here recently. How soon does reversal of ophthalmic flow occur following acute carotid occlusion? So can you get a hint whether this is an acute thrombosis by looking at the flow through the ophthalmic, or does it make any difference? Does it give you any indication of the chronicity of the occlusion before that reversal occurs?
I think that ophthalmic can reverse acutely. So I don't necessarily use that reverse ophthalmic to say this is a chronic ICA occlusion, because in that acute setting, again, I've seen, as you say, those acute ICA thrombus will result in the brain trying to obtain the blood flow anywhere it can. If there's not an adequate ACOM, that pressure difference that results will acutely just reverse the ophthalmic if it's still patent. So having that reverse ophthalmic does not directly lead me to say this is chronic ICA occlusion or stenosis. It can happen very acutely. So in that acute setting, you know, after I get my army of sonographers, the main vessel I would have them insonate up front would be the ophthalmic, because that will give me not just a peek at what's happening intracranially, but it will give me an understanding of what's happening in the neck. That if there's a tandem occlusion, we can find that with that one vessel and then go and insonate everything else. But that one vessel gives us that most information.
Thank you.
Aaron, I'll ask the last question.
Yes, sir.
Oh, we got one more coming in. So I'll ask mine, then we'll end with Andrew. First of all, Wayne Feng had to run to clinic, but he wanted to extend his congratulations, and he wanted you to say hello to Samir for him.
Yes, will do. From our time, I spent a lot of time in Cincinnati too, so but definitely I'll reach out to Dr. Belagaje, Samir, for Wayne. Not a problem.
Wonderful. So here's my question. I've been going to resident case conference in the morning. I'm an outsider to stroke. It seems like right now you can't come in with a stroke or TI without getting a CTA done in the emergency room. So does ultrasound add anything to the patient who's already had a CTA?
I believe it does, because what I'm finding is that, you know, ultimately with the high volume, we are seeing that I get to ask the question when the CTA report is normal. I get to ask the question, then why is there high velocities in the left MCA that's not present in the right MCA? And finding somebody with intracranial athero then doesn't put them down that cryptogenic stroke pathway. It then has a etiology of stroke that can be better found with active physiologic data that we're able to do at the bedside, and then also follow that on the outpatient side without then relying on the patient to come in twice for their CT angiogram follow-up with then a clinic appointment. So in that acute setting, if we say that the benefit is I'm finding maybe 5-10% of patients that the CTA is read as normal and I'm finding elevated velocities, that's about the rate that echo is finding significant finding that's changing our management, whether it's severe reduced ejection fraction or positive bubble study on the echo. So in my opinion, that TCDs and carotids can give that added direction of flow, just how this patient that I presented, the vertebral arteries kind of gave added information for what the basal artery was doing for this patient.
All right, thank you. And why don't we end with Andrew?
Yeah, all right, thanks, Aaron. I really appreciate you coming to give the talk today. I just wanted to ask if you'd give some advice to our trainees, our residents and fellows who want to follow this career path and gain proficiency in ultrasound, and how would you recommend they go about doing that?
Yes, I think it's exactly what Dr. Lukowitz was. I'm sorry, I probably Laskowitz. I ignored the S.
I've been called many things down south, and I'm not going to offend you.
Exactly, and I can't blame my accent from Indiana. But absolutely, I think exactly what Laskowitz was describing, getting that experience and that elective in the lab. We definitely have had our stroke fellows go on to get certified with TCDs and carotids and have taken that on in their career, whether it's out to Seattle or to Philadelphia, and using that as part of their career for acute stroke management and evaluation of our acute stroke patients. So that experience is just getting in front of the lab, getting hands-on probes, so you kind of know the experience that is needed in the technique, and then looking at the many different waveforms that we tend to find almost every day, that this is a different waveform. What signal is that describing for us?
Yeah, so for those of you who want to take the next level, I see there's a lot of typos in what I wrote. So many have elected to take many electives with us, and they'll go around with our TCD lab and look at the clinical picture and the angios and correlate. For those who want to get certified to actually make this a career path, we, and I'm sure many centers, and Aaron, I'm sure likely yours as well, require certification by the American Board of Neurosurgery. And to do that, you need 100 supervised studies in TCD and carotid, if you want to do carotid as well as the physics board. You can do that by working in the lab, or there's actually, in this area, many go to Awake Baptist. There's courses offered for neurovascular, to actually do the supervised studies, and then you could actually take the boards and get formally certified. So if anyone has an interest, I think it's a wonderful, underutilized methodology. And Aaron, thank you so much. It was really a great talk, and something we don't talk about enough. So thank you.
No, I very much agree. And I definitely, Chuck is one of my, mentors as well with education and getting folks as excited about TCDs and carotids as possible. It's impossible you're around Dr. Tegler and Dr. Alexandrov without saying, I want to get my hands on probe as much as possible. So.
Well, thank you, Aaron, and thank you for that final picture. Yeah, John Lewis, amazing guy.
Absolutely.
All right.
Absolutely. We usually post these on Twitter. Is there any? Do you have any objections to that? What do you think?
I have no objection. What am I posted on Twitter?
We record these grand rounds. I can send you a link, and people sometimes enjoy watching those as well. No. I can send you a recording.
No, that sounds perfect.
Awesome. Well, thank you so much.
No, thank you.
Thank you, Aaron. Be safe, everybody.